Hello and welcome to tonight's webinar, Know Your Options, Latest Evidence for Early Use of Chemotherapy and Immunotherapy in Prostate Cancer. I'm Sienna Breen, Patient Support Programs Coordinator at Zero, the End of Prostate Cancer, and I will be moderating the program this evening. Our guest presenter tonight is Dr. Kelvin Moses, Chief of Urology at Nashville General Hospital and Assistant Professor of Urologic Surgery at Vanderbilt University Medical Center. This program is hosted by Zero with support from both Dendreon and Sanofi. Just to give you all an overview of the program, we are expecting the webinar to last about an hour. In a moment, I will give a general overview of Zero as an organization and introduce our presenter, and then I will hand it over to Dr. Moses for his presentation. After his presentation, time allowing, we will have a question and answer session. At any time during the presentation, if you have a question, please type it in the chat box. I will flag all the questions I see, and we will get to as many as we can during the Q&A session. We are also recording this webinar and will post it on Zero's website, zerocancer.org, within the next few days. All right, I'm going to briefly introduce Zero for those of you who are not familiar with our organization. Zero, the End of Prostate Cancer, is the leading national nonprofit with the mission to end prostate cancer. Zero advances research, improves the lives of men and families, and inspires action. Our ultimate goal is to create Generation Zero, the first generation of men free from prostate cancer. And we are doing this through our National Run Walk series, education and patient support programs, and grassroots advocacy. Our presenter tonight is Dr. Kelvin Moses, Assistant Professor of Urologic Surgery at Vanderbilt University Medical Center and Chief of Urology at Nashville General Hospital in Nashville, Tennessee. He received his training at Emory University and completed a fellowship at Memorial Sloan Kettering Cancer Center, where he served as Chief Administrative Fellow. Clinically, he focuses on advanced prostate cancer, metastatic and castrate-resistant disease, as well as renal, bladder, and testicular cancer. Dr. Moses is also a member of Zero's Medical Advisory Board. All right, and I'm going to turn it over to Dr. Moses.
Thank you for having me, and I'm very appreciative to Zero for putting on this webinar, and hopefully this information will be helpful to the people who are listening. Again, please send in your questions as we go along, and we'll try to get to as many as possible. As an overview for the webinar, we'll go over a couple of scenarios and talk about the AUA-based guidelines, and that's the American Urological Association's guidelines for non-metastatic and metastatic castrate-resistant prostate cancer. We'll talk briefly about bone-targeted therapy and spend the majority of our time talking about some of the recent clinical trials that have been published, as well as some that are ongoing, looking at the role of chemotherapy and immunotherapy in advanced prostate cancer. As a disclosure, I am a member of the National Comprehensive Cancer Network Prostate Cancer Early Guidelines panel. As well, I serve on the Speakers Bureau for Astellas Pharmaceutical. So just an overview of prostate cancer in 2017. A little over 161,000 new cases will be diagnosed this year, which is actually a decline from the past 2 years. We did diagnosed over 180,000 in 2016 and over 220,000 in 2015. Up to 40% of men who are treated for localized prostate cancer, meaning they receive surgery or radiation, will experience recurrent disease in the form of either a rising PSA or metastatic cancer. Because fewer PSA tests are being performed over the last several years, fewer intermediate and high-risk prostate cancers are being diagnosed at the localized level. And what we are starting to see is what's called a reverse stage migration, meaning that more men are presenting with higher risk and higher stage disease who were formerly being found at lower grade and lower stage disease. Most men are treated with androgen deprivation therapy, which will be abbreviated ADT, for recurrence of prostate cancer, again, when there's a return of the PSA. And most men will eventually progress to what's called castration-resistant prostate cancer, either with or without metastasis. So let's discuss what is castrate-resistant prostate cancer. It is defined by disease progression despite being on ADT, and can present as one or any combination of a continuous rise in serum levels of prostate-specific antigen, or PSA, progression of pre-existing disease, or appearance of new metastases. The American Urological Association has set up guidelines for the treatment of non-metastatic as well as metastatic castrate-resistant prostate cancer. Now, this is a somewhat busy slide, but what it really basically shows is that there are different branch points in how the management of patients who are dealing with these diseases are managed. And basically the differences are whether there is metastases or no metastases, whether someone has received chemotherapy or not, and what their performance status is as determined by their activity level during the day. For patients who have non-metastatic castrate-resistant prostate cancer, the current gold standard is actually just to continue androgen deprivation therapy and obtain imaging, usually with a CT or bone scan, to see if there are any metastases. There are some people who use higher level imaging such as MRI or PET scans if there is a concern that there are metastases that are not being seen by standard imaging. Patients who have this status, meaning non-metastatic CRPC, can take anti-androgens such as bicalutamide, which is known as Castrate, flutamide or nilutamide, or enter clinical trials. And we will talk about some later in the discussion about non-metastatic, or what is called M0 CRPC. These patients should not be offered chemotherapy or immunotherapy outside of the context of a clinical trial, as the guidelines have not been updated to the most recent literature. For patients with metastatic, so that's mCRPC, but do not have symptoms, the current guidelines indicate that treatment can be abiraterone acetate plus prednisone, enzalutamide, and those two are hormonal therapies, which will not be the focus of the talk today. The other options include sipuleucel T, which is a version of immunotherapy, which we'll discuss in detail, and docetaxel, which is a form of chemotherapy. Also, we will talk about detail. First, we'll talk about immunotherapy. So the treatment is known as sipuleucel T. And what this cartoon shows is how this is managed or administered. First, a patient will go to a place like the American Red Cross, where the blood is drawn, just like if you would be donating blood, and the immune cells are harvested from this blood sample. They are activated by being put in the presence of a protein called GM-CSF, which is fused with another protein that is specific for prostate cancer. These activated cells are then reinfused back in the patient several days later, and these activated cells then go on to attack prostate cancer cells by causing death of those particular cells. This is an FDA-approved treatment for men with asymptomatic metastatic CRPC who have a life expectancy of greater than 6 months. Some common side effects that occur include fever and chills, nausea, back pain, infusion reactions, meaning pain or inflammation at the site of the infusion, hypertension. Very rarely has it been associated with stroke or thrombotic complications, but that is something that needs to be discussed with the patient. Poor candidates for sipuleucel T are those with symptomatic disease, rapidly progressive disease, which is usually indicated by a short PSA doubling time, those with limited life expectancy, and some people do avoid giving sipuleucel-T if there is a large burden of visceral metastasis, meaning metastasis to solid organs such as the lung or liver or brain. The data that was used for the approval of sipuleucel-T was what was called the EMBARK Trial, published in the New England Journal of Medicine back in 2010. Now, I don't expect everybody to understand the curves that are being shown, but in the top right, you can see what's called the median overall survival. And the median overall survival for those who received sipuleucel-T was 25.8 months versus those who received placebo, which was 21.7 months. So just over a 4-month improvement in median survival. What you see there where it says HR, meaning the hazard ratio, this is a number that indicates the risk of death of a particular treatment compared to the placebo. If that number is less than 1, that means that there is a lower risk, whereas if the number is greater than 1, it's an increased risk. And here you see the hazard ratio is 0.78, indicating a 22% lower risk of death of those who receive sipuleucel-T compared to those who receive placebo. Now, one interesting thing about sipuleucel-T is that there's not necessarily a PSA response or radiographic response while you're on the treatment or even immediately afterwards. What that means is that the PSA can go up or down. I've seen patients whose PSA jumps up dramatically but then ends up declining over time. This can be a little disconcerting because most men are used to getting their hormone therapy and seeing a steady decline in PSA. So this is something to be aware of if you are receiving this treatment. The trade name for this is Provenge. And as I mentioned before, the blood is drawn usually at American Red Cross or another approved facility, and this is typically done on like a Monday or a Tuesday. The blood is sent out for activation, and it is received back on a Thursday or Friday, and it is given as an infusion. It's given in 3 courses with 1 week in between each successive course, so a total of 6 weeks. The treatment itself costs approximately $100,000, but Medicare, as well as almost all insurances, will cover the vast majority of the cost. Additionally, the company does help provide transportation for people who need that, as well as other assistance. Now, one of the interesting things about the sipuleucel-T or Provenge is that the data that I've just shown was done under the guise of a clinical trial. However, subsequently to that, the company did what's called a registry data, which was called Proceed. And what this was about 1,900 men who received sipuleucel-T from 2011 to 2013 in what's called a real-world setting or outside the auspices of a clinical trial. Of that trial, 12% were African American, which reflects the actual proportion of the population of African Americans in the United States. And one of the interesting things they found is that although overall survival was better among all patients compared to placebo, African American patients had even greater improved survival compared to white men. As you can see here, overall, African American men saw 37.3 month survival compared to 28-month survival among white patients. And when the PSA was below the median, the survival was actually even more dramatic, where 54.3 month survival was seen in African American patients compared to 33 months in white men. And what these results indicate is that African American men may derive even increased benefit from sipuleucel-T compared to white men. This was presented at an abstract at the 2017 meeting of the AUA and is currently under manuscript preparation. The mechanism for this is not known. However, the company is undertaking investigation to see why this particular improvement is seen. We'll switch roles now, or switch direction now, to discuss chemotherapy and some of the data that has come out recently on the role of early chemotherapy in metastatic cancer as well as castrate-resistant prostate cancer. The most common first-line chemotherapy is docetaxel. What docetaxel does is it disrupts the microtubular network within cells. If you think about a cell, when it's every time it divides, it lines up almost like a scaffolding of a building. And what docetaxel does is it inhibits this creation of the scaffolding, which then inhibits mitosis or cell division. And as we likely know, cancer is uncontrolled cell division. There is FDA approval for docetaxel in men with metastatic CRPC and good performance status. Common side effects of docetaxel are fatigue, neuropathy or nerve pain, bone marrow suppression, which can be manifested by low blood counts, infection, hair loss, and nausea, vomiting. As a single agent, this chemotherapy is somewhat better tolerated than some of the combination therapies that are seen in other malignancies. People who are poor candidates are those with slowly progressing asymptomatic disease. Additionally, those with poor performance status. Again, just a little bit of the data. I won't harp on this too long, but there was a trial published back in 2004 making docetaxel one of the first treatments for metastatic CRPC. And as you can see, again, in that upper right-hand corner, median overall survival, meaning that 50% of men who received docetaxel every 3 weeks for 6 treatments survived 18.9 months versus a different chemotherapy, which had been the standard of care called mitoxantrone, which was 16.5 months. So these men had a median survival improvement of just over 3.5 months. Again, where we should see the hazard ratio or the risk of death of 0.76, meaning a 24% reduction in the risk of death of those patients who received docetaxel compared to the standard of care at that time, which was mitoxantrone. Going back to the AUA guidelines, for the patients who are symptomatic with metastatic CRPC and have good performance status, meaning they're out of bed more than 50% of their day and able to take care of their activities of daily living, and if they have had prior chemotherapy, they can receive docetaxel. They can receive the hormonal therapies, which are abiraterone and enzalutamide, or radium. Again, this is not something that we'll discuss now, but that is a different type of treatment that is targeted toward the bone. One thing that's important to know, for symptomatic men, do not offer immunotherapy or sipuleucel T. This is a recommendation against that according to the AUA guidelines. For patients with poor performance status, you can offer hormonal therapy in the form of abiraterone or enzalutamide, as well as bone-targeted therapy with radium. And if the poor performance status is directly related to the prostate cancer, meaning that the patient's pain or limited mobility is specifically due to the prostate cancer metastases, then you can offer chemotherapy, and those patients could have an improvement in their performance status because it is targeted against the disease. For patients who have received prior chemotherapy, meaning that they have gotten docetaxel before and now have recurrence or increasing PSA again, or progression of their disease, but still have good performance status, again, the hormonal therapies are available. But the big difference there now is a medication called, or chemotherapy called cabazitaxel, and that'll be the focus of this portion of the talk. Cabazitaxel is a family member of docetaxel, and it is FDA approved for metastatic CRPC after receiving docetaxel and with progression of disease. The main side effects for cabazitaxel is that it can increase prior neurotoxicity. So remember I said that with docetaxel, people can have peripheral nerve pain or numbness, and receipt of cabazitaxel can worsen this. And then again, bone marrow suppression is one side effect, and there's a higher risk of neutropenia, meaning a low white blood count, and a fever in the setting of a low white blood count called neutropenic fever. So patients who receive cabazitaxel will actually receive growth factor, Neulasta, which provides support for their immune system during treatment for cabazitaxel. Those who are poor candidates for cabazitaxel are those who are frail or did not tolerate docetaxel very well. The trial that was used to approve cabazitaxel as second-line chemotherapy was called the TROPIC trial. This was reported back in 2010. And as you can see, the overall survival of the patients who received cabazitaxel was 15.1 months compared to mitoxantrone, which was 12.7 months. So a little over 2 to 2.5 months increased survival. And if you can see in that bottom left of the graph, the hazard ratio of 0.7, meaning that it was a 30% reduction in the risk of death from prostate cancer for those who received cabazitaxel compared to the standard of care, which was mitoxantrone. Now, for patients with metastatic CRPC who have received prior chemotherapy and are of poor performance status, the main goal here is for palliative or supportive care. And this is very important because this is something that should be discussed way earlier when the patient is meeting with their urologist or medical oncologist, because most patients who are metastatic CRPC will progress to this point. And it's important to know the goals of care, the goals of quality of life, how aggressive patients want to be, and for how long. Palliative care is a way of patients de-escalating active treatment, but making sure to take care of their pain level so that they're not having significant symptoms from their disease. There are very select patients who can receive certain treatments if their performance status is directly related to the cancer. But it's very important, again, to make sure that patients and their families are aware of the support that can be given with palliative care. Just briefly, I'll talk about some of the bone-targeted therapies. In prostate cancer, the most common area of metastasis is the bone. And the purpose of bone-targeted therapy is to prevent skeletal-related events, or SREs. And skeletal-related events can be bone fracture, spinal cord compression, which can lead to neuropathic pain or even paralysis, surgery or radiation to the bone that is needed to stabilize certain fractures or areas that are of concern, or hypercalcemia or elevated calcium levels due to turnover of the bone and calcium being entered into the bloodstream. The two main therapies for men with metastatic disease for bone protection are zoledronic acid, which is known as Zometa. This is a monthly injection. The other one is denosumab or Xgeva, and this too is a monthly injection for bone protection. Now, one of the difficult things while people are going through the various treatments that I've discussed is that sometimes it is difficult to gauge response or progression. And especially if a patient is feeling better and their PSA is going up, or if their scans are clean, but the PSA is going up. So there are multiple factors that you can use to gauge response, which include the PSA trend and timing of each PSA, radiographic findings, but also what the patient reports to you as far as level of pain, fatigue, or performance status. And one of the examples of this is during the trials for Sipuleucel-T or Provenge. While the patients were getting on treatment for Provenge, they got PSA and multiple scans during that time. And if you can follow the blue line there, the patient starts out with a PSA of 20 or so. They receive the treatment, and the PSA goes up to almost 120 within 2 months. And then it declines, kind of bounces around. But it's only 29 months later when there's actual difference in the bone scan where there was truly radiographic progression. So even though the PSA had bounced around and gone to high numbers, it did not really mean that necessarily there would be a difference in the bone scan. And as you can see here on a bone scan for a patient 2 months after receiving Sipuleucel-T, which is the second image, you can see some arrows at areas of metastasis. But if you go over to the far right image at 18 months, where the PSA is still the same number, but those lesions are no longer showing up. So now I'm going to talk about some of the ongoing and recently reported clinical trials. Again, this is basically focused on immunotherapy and chemotherapy. So the CHARTED trial, which was reported back in 2015, was performed in men with metastatic hormone-sensitive prostate cancer. So this is a different population from the hormone-resistant. Those are patients who have been receiving androgen deprivation therapy and their PSA is going up. These are men who are showing up with metastatic disease who have not seen hormonal therapy. The gold standard up until this point was just to initiate hormonal therapy. But the CHARTED trial wanted to see if the addition of chemotherapy with docetaxel had improved outcomes compared to androgen deprivation alone. As you can see with the green line, those are the patients who received androgen deprivation and docetaxel. Their median overall survival was 57.6 months compared to those who just received androgen deprivation alone of 44 months. So over 13 months survival, that's over a year. Improved median survival of those who received chemotherapy and hormone therapy. And at the top, you see the hazard ratio of 0.61, meaning a 39% reduction in risk of death of those who death from prostate cancer of those who received androgen deprivation with docetaxel. One of the things they looked at during the trial was the burden of disease. And so what they looked at are patients with high volume disease compared to low volume disease. And as you can see at the bottom, the definition of high volume disease are those who had visceral metastasis, meaning metastasis to solid organs, or those who had at least 4 bone metastases, including at least 1 metastasis outside of the spine or ribs. And on the left, you can see the curve for the patients who had high volume disease. And they had a median survival of 49.2 months compared to those who just received hormone therapy alone of 32.2 months. So meaning with high volume disease, patients who received androgen deprivation and chemotherapy had a 17-month improvement in survival and a 40% reduction in death of those who received chemotherapy. In contrast, patients with low volume disease, there was not a statistical significant difference in median overall survival of those who received androgen deprivation and chemotherapy versus androgen deprivation alone. Now, the study was not powered to detect differences between high and low volume disease, but probably in practical terms out in the community, many physicians will tend to give chemotherapy for patients with higher volume disease based on these results. Now, another trial that just came out earlier this year called the Latitude Trial looked at also, again, a population of men with metastatic hormone-sensitive prostate cancer with abiraterone, which is also called Zytiga. This is one of the hormonal therapies that is given in addition to androgen deprivation therapy. And again, in this trial, what you see is that men who received abiraterone or Zytiga in addition to androgen deprivation therapy had improved overall survival compared to those who just received androgen deprivation alone. As you can see there, the top curve never reaches that hash line, which is the median survival. So the median survival was never even reached in this trial, whereas the placebo it did. And their hazard ratio of 0.62 means that there's a 38% decreased risk of death from prostate cancer for those who received abiraterone versus androgen deprivation alone. The other improvement that was seen was in radiographic progression-free survival, so meaning the length of time that a patient lived before new radiographic evidence showed up on a scan. And again, there was an improvement of radiographic progression-free survival of almost 2 years. And the hazard ratio here shows a 53% reduction in the evidence of new radiographic metastases for the patients who were on abiraterone. Now, I'm going to go through some of the trials that are ongoing now or recently closed, just to kind of talk about what's new on the horizon for metastatic or non-metastatic CRPC. One of these trials is PROSPER. This is for non-metastatic patients. Excuse me. And this will be randomized to patients who will receive enzalutamide, which is known as Xtandi, which is one of the second-line hormonal therapies, versus placebo. And their goal is to look at if there's a difference in metastasis-free survival, which is similar to radiographic progression-free survival. Another trial is the SPARTAN Trial, again in non-metastatic CRPC. They'll be receiving a novel therapy called ARN-509 compared to placebo. And again, the goal is to look at metastasis-free survival. The ARAMIS Trial, again in non-metastatic patients, will receive a novel agent from Bayer versus placebo. Again, metastasis-free survival. The EMBARK Trial is for high-risk non-metastatic patients who are hormone sensitive. So these are patients, let's say they have received radiation or prostatectomy, who now have rising PSA and have not been on androgen deprivation. And these patients will either get enzalutamide, one of the hormonal therapies, with or without Lupron, which is one of the common androgen deprivation medications, or placebo. And again, the metastasis-free survival is the goal for this study. One study that's going on in Europe is called the STAMPEDE Trial. And it's a little bit of a mixed population. And what the Europeans have done is said, let's look stepwise at different levels of disease and different combinations of therapy with the goal of determining if there's an improvement in overall survival. So there's actually multiple populations that are included in the STAMPEDE, including high-risk localized disease, where it says patient population number 1. Those patients have no nodal or metastatic disease. Group 2 are patients that have either positive lymph nodes or metastasis. And group 3 are patients who have received prior radical prostatectomy or radiation therapy, who are now bioclinically recurrent or have positive nodes or metastasis. And as you can see after the randomized bubble, there's several different therapies that have been tested. The ones with the red line through it have already been closed, and it's basically some version of androgen deprivation with either some of the bone-targeted therapies, hormonal-targeted therapies, or chemotherapy. The two at the bottom are the ones that are still open. So that's androgen deprivation and radiation to the prostate. That's for the high-risk localized patients. Or another portion of the trial is looking at androgen deprivation with a combination of the two hormonal therapies, abiraterone and enzalutamide. As of now, these are monotherapies, but the goal of this arm of the study to see if the combination of these two, which have different mechanisms, can act together to improve overall survival. So in summary, as you can see, there are several options available. One of the things that is not yet really known is what is the optimal sequence. Should we start with Provenge? Sipuleucel-T? Should we start with hormonal therapy? Should we start with chemotherapy? It's really individualized to the patient, their performance status, their disease progression, and their hormone sensitivity, as well as patient preference. You should definitely consider a multidisciplinary approach, and most clinics that see patients, such as in mine, is available. You can see a urologist, a medical oncologist, and radiation oncologist who can come together and try to come up with a personalized plan for you for your treatment. Additionally, clinical trials are a good option, especially for patients who have challenging cases, young patients with rapidly progressive disease, or those who are looking for options beyond just the standard of care. As we discussed, the charted data may indicate that early utilization of chemotherapy may be the better treatment for patients with high volume disease, whereas data from the Latitude trial may suggest a shift in treatment for patients with metastatic hormone-sensitive disease utilizing one of the second-line therapies. Thank you again for your attention to this. I look forward to the questions, and I again appreciate Zero and the sponsors for allowing me to give this presentation.
Thank you very much, Dr. Moses. So now we've come to our question and answer session. As mentioned at the beginning of the program, if you have a question, please type it into the chat box, and we will get to as many as we can with the time that we have left. The first question that I have flagged is, can chemotherapy and immunotherapy be the first treatment option for metastatic prostate cancer versus hormone therapy? I know you talked about this a little bit, but can you just reiterate, when do patients become eligible for chemotherapy or immunotherapy?
Yeah, so as of now, they're all for men with metastatic disease. Either one can be a first option. As of now, the charted data does indicate that docetaxel can be a first-line therapy. The benefit may be greater in those who have higher volume disease compared to lower volume disease, but there is an overall benefit. Immunotherapy can also be a first-line therapy for metastatic hormone or castrate-resistant prostate cancer. So the charted data, remember, is for men with metastatic hormone-sensitive disease, whereas Provenge or Sipuleucel-T is only approved as of now for men with metastatic castrate-resistant prostate cancer. So that's, again, where there's a couple of forks in the road that determine which options are available to you. Again, we have to take into account age, performance status, and rapidity of progression when we're talking about what would be the optimal first treatment.
Great, thank you. There was a second part to that question, which is, can African American men receive better results if this line of treatment is done first? I know you talked a little bit about the benefit of the overall survival benefit on Provenge for African American men versus white men. Have we seen anything like that with chemotherapy use?
Not yet. So as far as we know, the PROCEED data, which again is just an abstract form right now, it hasn't been published yet, but there's an indication that immunotherapy with sipuleucel T appears to have a greater response in African American men compared to white men. We have not seen that difference in chemotherapy or the other hormonal therapies.
Thank you. We have a question. When you were talking about the data for Provenge, I think the initial clinical trial data, you mentioned the term symptomatic and you mentioned the median PSA. Can you talk a little bit about what constitutes symptomatic disease and what you meant by the median PSA in that trial?
Okay, so symptomatic, that's a great question. We talk about symptomatic, we're talking about symptoms that we can reasonably surmise are from prostate cancer. So as we know, most of the men who have this are older, so aches and pains in the joints are not uncommon. But very specific bone pain that we have radiographic evidence of is something that we would call symptomatic. Additionally, you can even count fatigue as one of the symptoms, particularly if there's progressive disease, because, again, active cancer with a rapidly rising PSA can cause fatigue because those rapidly dividing cells need energy to keep reproducing. Now, what we mean by median PSA, that just means, median means the 50% mark. So half of the men had a PSA lower than that number, and half had a higher PSA than that number. So I think for that particular study, the median PSA was 26. So men whose PSA was less than 26 had an even greater improvement in survival with sipuleucel T compared to those whose PSA was higher. So most people who prescribe sipuleucel T or Provenge will typically give it in the earlier setting of metastatic castrate-resistant prostate cancer, meaning when the PSA is lower and when there are not as many metastases as evident on the scan. It can be given in those with a higher PSA or higher or more bone metastases on a scan, but they may not derive as much of a survival benefit compared to those who had a lower burden of disease.
Thank you, Dr. Moses. I know that you talked about this a little bit, but I got a couple of questions asking for you to just redefine or reiterate what you mean by castrate-resistant or castration-resistant disease.
Okay, I'm gonna swing back to that slide just so I make sure we're clear on that, because that's really a good point. So castrate-resistant prostate cancer. So that means that these are men who have been on androgen deprivation therapy, meaning they've been getting their Lupron shots or Firmagon or whatever type of shots they've been giving, and they have at least one of the following. Their PSA is continuously rising while being on androgen deprivation therapy, or there's progression of pre-existing disease, so meaning that someone has a lymph node that they've been following on scan that goes from 1 centimeter to 3 centimeters, or they have a bone scan that shows an increased size of disease, or the appearance of new metastases. So someone who's been trucking along and their PSA is slowly going up, but you get a bone scan that shows some bone metastases. Any of those would be qualified as castrate-resistant prostate cancer.
Thank you for going over that with us again. The next question, I think this question is, they want to know if they can take either Xtandi or Zytiga with Taxotere, but without ADT.
There have not been any trials that would indicate that. All of the trials for Taxotere or docetaxel, as well as the hormonal therapy, the patients continued on androgen deprivation therapy indefinitely. That would be an excellent trial. So looking at receiving chemotherapy with one of those second-line medications, but there have not been any trials that have been performed that would look at that. So that would not be advised as of this point because there's no evidence to indicate that that would give a survival.
Thank you. The next question I have is, with the incidence of recurrent disease or diagnosis with advanced disease, what medical specialty is the right treating doctor?
So most of the patients who have recurrent disease is probably found by their urologist who they've been seeing, who did their initial treatment, or even their primary care physician who sees that there's an increasing PSA. I think the right doctor is someone who specializes in managing this type of scenario. So there are urologists such as myself who deal with this, medical oncologists who deal with this. And in certain instances, even a radiation oncologist can be helpful if it's locally recurrent disease. But certainly your medical oncologist or urologist who are well versed in this, who are prostate cancer specialists, would be the ones that you would want to consult with.
Thank you. The next question that we have is, are there any other current clinical trials underway for immunotherapy or chemotherapy?
Yeah, so there are, so I mentioned some of the trials here. For immunotherapy, there was a bit of a hold with the company that administers Sipuleucel LT, but they have some trials that are coming on board with combination therapies as well as secondary treatment. There's another trial, I think mostly going on in Europe, but even in the United States, called Prostavac that's going on. And then there are several chemotherapy trials. There's always chemotherapy trials going on, usually with combination of some of the novel agents. I didn't get into some of the alternate hormonal therapies. There are what are called PARP inhibitors, PARP, in combination with chemotherapy or hormonal therapy. There are combinations with PD-1 inhibitors. You've seen commercials for one of the lung cancer drugs that's a PD-1 specific. Those have been used in combination and looked at in prostate cancer. So one of the ways to find out what's available in metastatic or castrate-resistant prostate cancer is go to clinicaltrials.gov. That's clinicaltrials, all one word, .gov. And they have a search bar where you can type in prostate cancer or metastatic prostate cancer. And you'll see there's a plethora of trials going on in the prostate cancer arena.
Thank you very much. We have somebody asking, what were your recommendations for non-metastatic prostate cancer on the first couple of slides? What did you talk about?
I'll go back to that.
Okay.
So again, the current standard of care is just to continue your androgen deprivation therapy. So if you're on Lupron shots or Pharmagon or again, whatever plethora of shots that are out there, I would suggest restaging with scans. And then if people are just on a shot, you can add an anti-androgen, which is called bicalutamide or flutamide or nilutamide, and these are pills, those are oral medications. Ketoconazole is not commonly given. I haven't seen anybody give that in a long time. And then if you have been on dual therapy, meaning you've been on Lupron shot and an anti-androgen, you can actually stop the anti-androgen. So people who have been on Casodex along with their Lupron shots, you can actually stop the Casodex, and in about a third of men, the PSA will actually start going back down, and in another third of men, the PSA will sort of stabilize. So in that instance, for non-metastatic disease, those are the options: staying on androgen deprivation and either starting anti-androgen, or as we've mentioned before, several of those clinical trials are in the non-metastatic space.
Thank you very much. Since you started talking about scans, I got a question: is the C11 scan beneficial compared with other scans, and why is the availability so limited? Is that something that you know about? I'm not personally familiar with that.
Yeah, so a choline scan. So the issue with the standard PET scan is that the metabolite that's used is processed by your kidneys. So it shows up in the urine and it's very bright, and so it tends to wash out pelvic lymph nodes and wash out areas up near the kidney. So there are some scans that are now available, including a sodium fluoride PET scan, which is not processed by the kidneys, or the C11 or choline scan. They are a little bit higher resolution because you don't get washed out in the urine. The availability is really the cost. So if you can imagine, any imaging center, every time a new type of imaging comes out, it requires new equipment, new software, someone who is well-versed in looking at that. And so, and as far as C11, the utility of prostate cancer is still relatively new. So I think people are also kind of waiting to be more convinced. The other thing is they're very expensive. PET scans, they can run $3,000 to $5,000. C11 scans are probably right along that same area. So even though you may get more information, that definitely comes at a cost.
Thank you very much, Dr. Moses. That was actually our last question. So that brings us to the end of our program. Just as a reminder to everyone who is listening in, the recorded program will be made available on Zero's website, zerocancer.org, within the next few days. So thank you very much again to Dr. Moses for being with us tonight and for sharing your expertise. We would also like to thank our sponsors, Dendreon and Sanofi, for supporting this program and making it possible. Thank you very much to everyone who joined us tonight, and just so you know, when you close out of the program, you will be taken to a post-webinar survey. If you can, please take the time to fill that out. We really value your feedback, and it helps us plan future programs and improve the series. So this concludes our webinar. Thank you again to Dr. Moses and to everyone who tuned in, and have a great evening.